Hello, everyone. Thanks again for joining in from different corners of the world. And first of all, and I mean, I really appreciate the people who wake up at 3 or 2 a.m. to log in and not to just underestimate the energy and effort which is being going in. And my name is Kuchal, and I'm going to pass the mic to Ravi. And thanks a lot, Ravi, to have me and to co-discuss with you the case. And I'm excited to learn today.
Thank you, Kushal. If anybody doesn't know, Kushal is now logging in from India. I guess a wee hour, no, actually, so evening hours, and you're about to catch a flight back to New York pretty soon. So we're going to have this hour of power. So welcome everybody to Tuesday VMR. It's my first time co-discussing with you, right, Kushal? And before we get underway, I want to introduce our case presenter today. We have Sime, everybody knows Sime's sister, who is a resident in New York. Noor, you want to unmute and just say hello and just tell us a little bit about yourself?
Hi, thank you so much, Dr. Ravi, for your kind words. I'm Noor. I'm an intern in Maimonides Medical Center, and I'm very excited to present a case today.
Tell us one thing about New York that you like or you've grown to love.
People, the energy.
And energy, right? And what's your favorite food there that you like?
Oh, a lot. Pizzas, just like
There
you
were,
mentioned.
we were just talking about that. Yeah, there's a ongoing debate between New York and New Jersey about the best pizza. So Brooklyn, you do find excellent pizza. So thank you for putting a case together and bringing it for us today. And we'll also introduce the people that without whom we can't do this. Seema is going to be doing scribing, and Julie is going to be doing teaching points. Seema, you want to unmute and just say hello?
Hi everyone, very excited for the session today. And I just read the comment by Lira that I have good recruitment skills. So just very excited for Noor's case today. Hope you all enjoy it.
All right, and Julia, how are you?
Hello everyone. Very excited for Nora's case and welcome to CP Silver's Academy.
Awesome. So we'll hand the mic over to Noor for the first aliquot.
Mhm. Okay, so let's start. This is the story of a 45-year-old female who comes to the ED for altered mental status and because she has been nonverbal for one day. And I'll stop here.
Pretty interesting. Kushal, you want to take first stab at this?
So the first thing which I am thinking of when a person is actually saying their altered mental status and is that who noticed it, and then they say it's for one day. So we do know that there is this. I would want to know what's her baseline mental status before she became altered, and at times, and then there's non-verbal which is being mentioned too. So, and I would want to know if there was an inciting event which happened before her mentation got altered, or did she just wake up and then they found her to not have the normal mentation. And the other thing which I would also want to know is that what's her past medical history, and whether you know her basic history, whether she's already having a dementia and it just became worse, or if she was like all right and she was just independent in her living activities, and suddenly they found that she was nonverbal. So the thing which I would be concerned in a person who is like normal at their baseline and independent and they become non-verbal is that if they're having a stroke, and whether it's like the different places where they can have the lesion when they're becoming non-verbal, if she had a shock and and that's when she stopped talking, and or if it was to do with something either embolic stroke or thrombotic lesion which is happening. And then I would also want to know that if she's having any other problem or like a weakness, numbness, and if it was like progressive and then suddenly there was lesions which were already there which was like progressively getting worsened, and it's only with when she became non-verbal is when they come to the hospital. These are the couple of things which I'm thinking of. And the other thing which I'm thinking of is that if the person is having fever, or if they don't have any fever, like it's like febrile or non-febrile. And then also want to know if the person is having risk factors like, hypertensive, diabetic, and if they're 45 years, they still like in the reproductive age group. So I would also want to know if she actually had a delivery recently, and or if she's pregnant. So those would also be things which I'm thinking of, apart from her social history of, what if they're on any drugs, if they smoke, if they drink alcohol. And so these are all the things which I'm thinking of. And also I would want to know if the person had a long flight, for instance, and what's their mobility status, like if they had diarrhea, and then and then they just suddenly were very weak, and then now they become non-verbal. So these are few things which I'm thinking of. And Ravi, what are the other things which you would you like to walk us through?
Yeah, I just love how you just started this narrative and trying to break down what's going on. I think what you mentioned, getting the backstory is very important. So, what kind of baggage is the patient bringing? Is there a history of maybe use of substances? Is the patient maybe at risk of withdrawing from something? Looking at the time frame also, I think, this is sudden. If you think about what kind of things usually can occur minutes to hours, you can have seizure, stroke, metabolic issues, you can have an overdose or toxicity, hypoxemia, things like that. So this is acute. This is something that happened very quickly, and usually it's like a quick, fast insult to the brain. Many different kind of systems do contribute to mentation, and you look at the brain, you look at the milieu around the brain, then you look at distal effects that could have an upstream effect on the brain as well. The other kind of stuff like infections are sort of slow going. They would take kind of days. Metabolic issues also don't suddenly, unless you get an effusion. Metabolic issues, except for like hypoglycemia, though, they usually do take time to occur. So I wouldn't think it within a day you would have a metabolic or endocrinological kind of condition. If you think about infections of the brain, usually encephalitis will cause autoimmune status. Meningitis usually will take some days because it's affecting different anatomical layers of the brain. So that also has a prodrome. It has a buildup. So with this, it's interesting. 45 years of age, what kind of things could you pin there? It's still a younger person. You would think about what is common would be common in that case, like if they have a backstory of diabetes, maybe hypoglycemia. If they have a backstory of substance use disorder, maybe one of those things, intoxication and things like that. So at this juncture, I think getting backstory and also kind of surveying the field, looking at the patient. So before even jumping into the exam, looking at the patient, how they are. Do they look sick or non-sick? Sick patient could be septic, may need emergency and stabilization. So stabilization is key in this case. The other most important thing is when I do simulation, when we have altered mental status as a scenario, is valuing the patient if they can protect the airway. So very important before you dive deep into frameworks, mist, mnemonic, and so on. You need to make sure the patient is stable. Otherwise, during your pondering over the possible causes, patient could actually have a cardiac arrest or could have a code event in this case. So stabilization is key, surveying the area, then examining eyes. Eyes can actually reflect internal conditions as well. So like pinpoint disorders, pinpoint pupils could signify substance use disorder, or maybe like a pontine hemorrhage, or maybe a CNS issue. Discordant pupils could manifest with maybe herniation of the brainstem and things of that nature. So at this juncture, I think we need more backstory before we can start elaborating on what could be going on. Any other thoughts before we hand the mic back over?
Yeah, the only other thing, I think like you covered like everything. And the only other thing I would also want to add is like if it's happened before and if it's like a recurrent issue with this patient or if this is the first time is something else which I would also want to know from.
Okay, Noor, back to you.
Amazing discussion. So we took some further history from husband who was at the bedside, and he said that this all started like a week ago. She had a subjective fever and she was lethargic last week. She took some Chinese medications for her fever. Then around 12 a.m. previous night, she was reported to have collapsed on the floor. There was no loss of consciousness, no head strike. And then at 4 a.m., she was not following any commands and she was not walking. In the ED, she then has a witnessed generalized tonic-clonic seizure, and she's given Ativan and Keppra for that. She was post-ictal for unknown duration. And then in the ED, she later becomes agitated, and she's given haloperidol. Husband also says that patient has been acting more agitated and has been acting weird for last week. As for her baseline, she was like AO times 3, and this was like the first episode or first time when she experienced something like this. And I'll stop there.
Okay, Kushal, we have backstory, and this backstory definitely helps us to lay down the groundwork on which we can follow to decipher what's going on. And here we have a couple of things. I think the chat, Hans Lake has mentioned the fever and the Chinese medicine. So these are two different things. They may have something to do with this. They may not have something to do with this, but fever can be a very strong signal. When you think about fever by itself, the number one thing we have to think about is infection. So we do have to invest some system two thinking in fever, altered mental status, and the different causes. The other thing is this Chinese medicine for the fever. But the thing is, though, this could be a something that may not have any bearing on this because the fever happened and this was the initiation of her decline, a cognitive decline or partial cognitive decline. That medicine was taken for the fever. So I think we have to do our due diligence and try and solve fever with decline in altered mental status. Then kind of think about what kind of medicine is this that the patient took. So if you think about fever, you can't help but think about the two conditions we initially had kind of tackled: encephalitis, meningitis. So usually encephalitis, you tend to have more altered mental status. You will tend to have more seizures, may have more focal neurological deficits as well. So these things we will have to evaluate when we go through the examination. And then a lot of times we may want to perform an exam in the manner of a hypothesis-directed physical examination. So if our hypothesis is encephalitis, meningitis, we may want to start with the head and then look for any nuchal rigidity, Kernig sign, Brzezinski's, and so on, and then also do a neurological exam. Sometimes, it's interesting, like altered mental status is one of the most difficult cases to admit to the hospital because the patient's not talking to you, the patient's not telling you, I have these problems and so on. So it's very helpful that the husband's at the bedside to give us this history. Otherwise, it's very difficult to ascertain like the groundwork before the patient came in. Like for this week, there was this fever and lethargy as well. So there is this sort of strong association with possible buildup of an infection. After infections, we may have to start looking for other causes of fever. But if we do get in the labs a strong signal for like infection, such as elevated white count, then we have no other choice but to pursue the workup of infections. It won't always have to be the infection of the brain or the meninges, but other infections could manifest if you have a sepsis syndrome that can cause deterioration in mental status. The top two infections usually pneumonia, UTI, which can actually cause SIRS and sepsis and cause altered mental status. Although at this age is very unusual, but yeah, at this point, I am strongly considering infections, strongly considering encephalitis, meningitis. This collapsing on the floor also. She became weak and she fell to the floor. We don't know if there was a seizure involved or not, but that can also can be associated with encephalitis. And anything to add, Kushal? I'll stop there.
Yeah, I think like I was thinking whether, the Chinese medicine itself, if it's like the patient, if the problem actually which we are dealing with is actually patient with fever and altered mental status, whether Chinese medicine is a noise, or if the Chinese medicine is a signal, which like then leads us to think of whether a person with fever was not drinking good amount of water, already had a pre-existing low-key AKI. With more intake of Chinese medicine, they are prone for a nephrotoxicity and then worsening of the things, and if she's uremic. Or she could also have an hepatotoxicity because of the Chinese medicine, then which is causing her to have an encephalopathy, and worsening with of the fever, and then that's fever and the causing her to have an altered mental status, and then probably precipitating a seizure. So if that is actually a signal, or if it's just a noise, and then what's happening with her is like the way Ravi like beautifully explained, it's an infectious thing and which we wouldn't want to miss out on, and treat her immediately for would be either it's a patient with a primary issue of a meningitis or an encephalitis, and look for left shift if the count itself is within normal limits, or if she's having nuclear rigidity, and if she's having any eye signs, any rash, if she had any rash exposure to tick, or anyone else at home had similar issue recently or before, and to get to do the lumbar puncture, to get a CT of the head to make sure there's no mass or there is no increase in intracranial pressure before you could actually proceed with the LP, and then also to not delay the treatment itself for meningitis, because we did have a patient who um, basically she kept being altered, and I think this happened last year when they thought it was multiple things which was going on, and then there was very low risk or to consider it to be a meningitis. They just had it as a very low in their differentials when they presented the case in the morning report, and they missed it, and before the time they could actually get the report back from the culture sensitivity back, they had already lost the patient, because sometimes meningitis can be rapidly progressive. So you would have to treat that immediately, and you wouldn't want to lose the patient. So these are all the things which are actually going on in my mind. Yeah.
Okay, wonderful, Kushal. Yeah, I think we're thinking alike. So I think the workup is necessary for CNS infection. Back to you, Noor.
Amazing discussion, guys. So I'll give you some more context. A past medical history. Patient has a history of metastatic breast cancer to brain, status post craniotomy that was treated with radiation. Past surgical history, craniotomy for metastatic cancer. And the meds that patient is on are letrozole, 2.5 milligrams daily, Keppra, 500 milligrams Q12, pantoprazole, 40 milligrams daily, and ribociclib. Allergies, she was not allergic to anything. For social history, she had like some past history of smoking and marijuana as a teenager, but like that was years ago and nothing anymore. No recent travels. She moved to United States from China 20 years back. And I'll stop there.
Kushal, your turn now.
Yeah, wow. So it's very concerning. And then the history which we have elicited so far, Noor, thanks a lot for sharing this case with us. So I'm not completely sure as to which class of drug the ribociclib would fall under. Noor, do you know if it's a what kind of drug that is?
It is a CDK4 inhibitor.
Okay, so and then the patient is already on Keppra. So I'm wondering if she missed the dose of Keppra because she was already having some amount of altered status, which was going on from for a week. She had the fever. So one of those things which I'm thinking of is that, and if there's like when a patient is having metastatic cancer and to the brain, with like if they did remove all the lesions which were in the brain, and also sometimes breast cancer can be so aggressive despite taking chemotherapy, and having been good with your medication, they could be so aggressive to have a recurrence. And some just wondering if that she's have some amount of recurrence happening, or if she's having any kind of drug toxicity which is happening, given the fact that she's on CD4K inhibitor, and then she took a Chinese medication. And I'm not quite sure if we have enough studies to actually have studied if they are do not affect do not cause a toxicity of either of the drugs, or how they interact. And that's something which I would be concerned about and worried about. And yeah, so though, and yeah, that's what I am thinking about. Ravi, what are you thinking about?
Absolutely, yeah. I think the question is, you're absolutely right. You have to consider now this other medicine. The immune status of this patient comes into play now with patients being on this medication, this inhibitor. She's immunocompromised and ripe for infection. So right now, I am thinking with this history of Mets to the brain, and there's surgery and so on. So could there be, number one, an extension of this? Number two, immunocompromised status. Could there be infection? Number three, toxicity, seizure from this Chinese medicine, which could, I mean, how do medicines potentiate this kind of presentation? Maybe they lower the seizure threshold, and she also didn't take maybe her anti-epileptics. And you can get breakthrough seizures in this case as well. So right now, infection, extension, and then toxicity are things that I'm thinking about. Fourth thing, you could say this CDK4 inhibitor, could it potentiate other issues? So could it affect other glands or other systems within the body, which could culminate in a altered mental status in this manner? The fever, very strong signal for infection, but fever could also be of a non-infectious inflammatory etiology, like endocrinological conditions, like autoimmune phenomena. So you can't help but think of those as well. But I think what we need to sort of at least rule out the most common things, at least before we move laterally to other causes which are non-infectious. Because time, like you mentioned, time is key here. You allow an infection to sort of fester, and it could potentiate into sepsis, septic shock, and multi-organ dysfunction syndrome. So we got to be really careful here. So what would I do in this case? If we switch, we sort of have to play in or consider two areas. One is what is going on. Second is what do we need to do at this time? Within 60 minutes, give her IV antibiotics. You may see like, wait, we don't have a diagnosis at this point. But if you have a high pretest probability at this point, antibiotics, imaging, because she had altered mental status and seizure, then you do LP. So very important. And she has immunocompromised status. So those are very important to when if you do step two or for the shelf exam. This is a point or a bullet point that we discuss with the students. Usually they get tested on. So any of these like altered mental status, seizures, previous intracranial surgery, which he's had before, and then also if patients on blood thinners, in this case, an immunocompromised status and focal neurological deficits, you must do a CT before LP. Any other thoughts before we swing the mic back over to Noor?
Yeah, the other thing is also ICIs. They are known to cause hypophysitis. I think there are a couple of studies which, and also if I'm not mistaken, there have been cases which have been present in our morning report, and that can cause like adrenal insufficiency and then worsening the whole thing. So I would want to have a very low threshold to give her some amount of steroids, because there is just nothing we could do if they didn't have that and if they were going for a failure. So those are the things which I would be concerned about. And I wouldn't really hesitate to include hemonc in my team, as well as neurology consult like ASAP. Yeah. And
Oh, very
IVF.
good. Yeah, very good thought. Yeah, I think mimickers of infection, adrenal insufficiency. So both here, primary adrenal insufficiency and secondary adrenal insufficiency are fair game. And I think the labs, usually there's a unique pattern which you recognize with adrenal involvement, and we'll look for that in the labs as well. So, Mike, back over to Noor for the next aliquot.
Thank you, and amazing discussion so far. We were thinking along the similar lines, and I'll give you some vitals for the patient. So, vitals, patient actually did not have a fever. So, patient was afebrile in the ED. Heart rate was 65, blood pressure 127 over 68, respiratory rate 20, and setting fine on room air 99%. On exam, patient did not appear to be in distress. Mental status, she was alert, but she was not responsive and she was not following any commands. She had global aphasia. Pupils were equal and reactive to light. On motor exam, no focal motor or sensory deficits were found, no photophobia, no neck stiffness. Reflexes were 2 plus, and planters were downgoing. Other than that, the respiratory exam, cardiac exam, and abdominal exam were pretty much unremarkable. I'll also give you some labs. So, white cell count was elevated at 12.1, with neutrophils 78.1, hemoglobin was 13.5, platelets were okay at 298, BMP was also kind of unremarkable, sodium of 140, potassium 3.9, chloride 102, bicarb 24, BUN 24, and creatinine was 0.8. LFTs were also normal. Flu RSV COVID was done, that was negative. UA was done, which was unremarkable. TSH was 0.8, which was also normal. A chest x-ray was done. There were no focal infiltrates. EKG, normal sinus rhythm. On echo, ejection fraction was normal, and urine drug screen was negative. And I'll stop there.
Hey, wonderful exam, wonderfully presented, Noor. So very interesting. I'll tackle the exam, and then Kushal, you tackle the labs here. So, fortunately, no raging fever, but fever is not always continuous. So even though the patient say febrile at this point, then she may have taken some medicine prior to arrival. The heart rate's interesting though. Yeah, currently she doesn't have fever, but usually you look for an uptick in the heart rate if she has a fever as well. So corresponding like 1 degree elevation Fahrenheit will uh, result in like probably 8 to 10 increased heart rate beats per minute. But here 65, she's afebrile. And then SATs are normal, respiratory rate a little high, so a little tachypnic. And then generally she's alert but unresponsive, not following commands. So it parallels the altered mental status chief complaint that she had in the beginning. And she's having global aphasia. So definitely we had honed in on the neurological system being affected here. So we'll have to see, like, well, is this global aphasia just part of her, just her mental status overall being affected, or does she have actually localized neurological injury causing this global aphasia? Pupils are equal and down going planters. So no upper motor neuron issues here that we're thinking about. No neck stiffness. So even if we're still thinking neck stiffness, does that rule out the likelihood of encephalitis meningitis? I would say no. These tests they're good when they are there, they're very good. But when they're not there, they don't necessarily rule out meningitis or encephalitis. So I think we still have to follow the path and do the workup. And if it is negative, we kind of discard that to the side and then just continue to work through considering all the other differentials that we were thinking about. Kushal, you want to tackle the labs here?
Sure. I think like when I have a bite count of being 12.1, um, I'm still like if I'm still thinking like uh, I mean like high on differential would be infectious cause, and but then all the other labs are like negative is what I see. So I would definitely want to repeat the blood um, once more, like within 6 hours or the next day, and to trend that and then see if something, if there's any change or if there's any difference which is there. And I'm also concerned about the heart rate for the presentation of a fever with it's like almost like a fever with bradycardia. I mean, like, so I would want to know if, like, if it's a drug toxicity and if she's also having some underlying cardiac toxicity, which is happening, and if that's the reason why um, she's not able to have a good response, cardiac response to the fever itself. And the other thing which I'm thinking of is that at some point we would want, I would be more concerned of actually stabilizing this patient than to actually, my mind isn't really, yeah, we need to find out as to what the organism is and if it is an infectious cause. But what I am prioritizing is to make sure the patient's airway is good, and if I have sent all the labs, can get the imaging done and secure the line and make sure that she's been loaded with Keppra, and also to send the labs for the value of the Keppra levels itself, and then see if I would have to give, or double the dose, load the dose, and make sure that if it's like her level was already, of Keppra levels were already good, and if she had a seizure, then we are thinking of it's like a breakthrough seizure, so she would be have to be on a different drug and like an additional drug. But then if the dosage, or if the her blood level of Keppra is like subtherapeutic, then there's a very high chance that she needs just a higher dose of just the Keppra and she should be good. So I wouldn't want to have a patient seizing in front of me. It just like worsens things or makes it more difficult. So I would want to make sure that we're able to like get that set properly. And also the other thing I would be concerned about is if she's having aphasia, and if she had a seizure, like if she had any aspiration going on, and if she did aspirate something, like I do see that the chest x-ray at the moment doesn't show any focal infiltrates, but we would want to make sure that she's having aspiration precautions, and all that is also set aside, and make sure that like at least we get all those things in place. And the next thing which I would be concerned or thinking about if I had this patient in the ED is to whether I need to, if she's stable enough to be admitted on the floors, or if I really would want to have the patient in the ICU and to check her vitals like more frequently and have one-on-one in treatment at the moment for her. So these are few of the other things which I'm thinking of before, or apart from apart from all the things which Dr. Ravi like elaborated on in terms of giving empiric antibiotic and getting her cultures done. Ravi, did you want to add anything before we pass the mic to Noor?
No, absolutely wonderful. Yeah, I think I was when you mentioned adrenal insufficiency, I was like excited to see, do we have the usual signature in the labs, hypernatremia, hyperkalemia, NAGMA, hyperglycemia, maybe, but none of we're having none of that. So that diagnosis kind of put on the back burner for now. So, but let's continue on the infectious path and see. Definitely would want to get CT, LP, start antibiotics and see what happens. Back to you, Noor.
Mhm. So amazing discussion. We got CAT scan in the ED. So CAT scan of the head, it just showed some post-surgical changes to right calvarium and underlying brain parenchyma, but there was no large intracranial hemorrhage or midline shift. A CTA head and neck was also done, and there was no definite evidence of any large vessel occlusion. A CT spine was done because patient had a fall and there was no evidence of like any cervical, thoracic, or lumbar pathology. And then I'll give you EEG results for this aliquot. There was abundant generalized rhythmic delta activity, which is a non-specific finding that can be seen in the setting of toxic metabolic derangements, deep structural lesions, and increased intracranial pressure. And we did an LP, so I'll discuss the LP results in the next aliquot, and I'll stop here for now.
Okay, so we at least got imaging, which is very helpful here, at least ruling out any structural abnormalities that could result in such a presentation. I'd be worried about any intracranial hemorrhage, any intracranial mass, possibly contributing to these seizures. Like you mentioned, any injury, maybe there's new metastasis as well with vasogenic edema and maybe midline shift, and that potentiating this ultimate status and also these seizures. However, the CT head does exclude a lot of potential pathology here, so we put that on the sideline for now, and then look at this EEG. So the EEG, it kind of would. So EEGs are interesting in this case. You're looking for, you know, that she had a seizure, so EEG could be helpful. Say she's altered and not having generalized tonic-clonic features, but she could have something called non-convulsive status epilepticus. So usually there's somebody who's going in and out of consciousness, not really having the generalized tonic-clonic features, but then waking up, looking around, looking at the clock, looking at the wall, and then going back into their altered mentation. So this happens just sort of almost like rhythmically. And an EEG is a good way to catch this. Sometimes there's no feature that you could really utilize to make this diagnosis, but getting an EEG and then looking at the recurrent seizures that are happening, whereas the patient's just not manifesting with that externally, could be a good way to catch it. But here we're having abundant generalized rhythmic delta activity, which is non-specific. And this could be in the setting of toxic metabolic derangements, increased intracranial. So the increased intracranial pressure is interesting. So what if there is CSF, like high protein in the CSF, or in this immunocompromised manner, what organism tends to cause very high intracranial pressure? You have to start thinking about fungal meningitis or cryptococcal meningitis. But I think most common sort of infections to think about right now, viral infections. So you have to think about the herpes viruses, arboviruses, and then some of the mosquito-borne illnesses as well. It depends on the time of year as well. So usually the mosquito-borne or arboviruses are usually around the summertime. I'm not sure what time of the year this patient's presenting with. Any thoughts, Kushal? I think the LP really will be helpful in this case.
Yeah, definitely LP is going to be very helpful. And the other thing is like the global aphasia and the CT findings doesn't really, I mean, there are certain features of HSV. We had a case which was present in the morning report last week where the MRI or the CT didn't really show anything for HSV because it was done very early in the disease process itself. So it needs to be repeated at least like 24 to 48 hours later to see if there's new features. But I'm also concerned whether if it's just the global aphasia post-ictal state, and that's why she's having. That's like one thing which I would want to, like follow up with the patient and reassess her to see if there's any improvement in any of her neurological features which she have had from the initial assessment. So, and then I would be able to make the diagnosis if it's just post-ictal or if there's actually something which is going on which we haven't really explained. So the next thing which I also would be concerned about would be is that her EKG does show, and I mean doesn't really show anything at all. So and her heart rate is like at 65. So one is like I would want to just repeat that and see. And then I would also, if she had an old EKG, I mean, the fact that the patient has such elaborate past medical history and then multiple things going on in the past, definitely there would be records available. So just compare it from her previous time and see if there's any difference. And so that would be something which I would also do. And the other thing which I would be doing would be is to um, yeah. So yeah, these are actually the things which, and if I forgot the what's the other thing, and once I remember it, then I will just like share that as well. Ravi, did you
Okay.
want to share something or?
I don't know. Let's see what Noor has in store for us. Take it away, Noor.
Amazing discussion, guys. We're thinking along the similar lines, and we had also started the patient on acyclovir. We got an LP on the patient, so I'll just share the results. So on LP, opening pressure was normal. Protein was 38, which is normal being 15 to 45. Glucose is 55, which is normal again, the range being 40 to 85. White blood cells are 7, which are elevated, normal 0 to 5, and 93% lymphocytes. RBCs are 10, mildly elevated, normal are 0 to 5. Other tests like Lyme was negative, Cryptococcus was negative, VTRL was non-reactive. PCR was done and viruses were not detected. CMV, EBV, VZV, and enterovirus HSV1 and 2 all negative. Cytology, no malignancy. And at this point, we involved neurology on board. And I'll stop here. And the next aliquot would reveal the diagnosis. Also, an MRI was done and there were no significant findings there either.
What do you think, Kushal?
Yeah, so I'm not quite sure if this would be the lab picture for a CSF findings for aseptic meningitis, and I think patients on with cancer or patients with immunocheckpoint inhibitors are at high risk of getting them. So I am not absolutely sure if this would be the CSF findings for that. So that's another thought which I would want to consider and just one a fun fact which I wanted to share was that I never knew that open evidence wasn't available in India till now. So I would really be apparently then yeah. So if we are in the US, then I would definitely get the help of open evidence to see if that's going to be happening. And the other thing which I would be, I'm really little bit more relieved to as a PGY2 resident is to have the neurology on board and to make sure that I'm having the patient stabilized, and I'm thinking of whether if we would have to also have the intercollaborative workup between the oncology and the neurology. And when the ID is on board, and I'm glad that she's getting the acyclovir, so at least like the main important things which we are concerned about, yeah, the labs were negative for the viruses so far, but I would never be surprised if a lab just calls up at any point and then they say, oh, yeah, this one sample did have something growing. So I would always have that, be on an eye alert. And yeah, so that's where I am at, Ravi.
Yeah, at this point, a lot of the PCR doesn't detect the viruses that we're thinking about. So herpes viruses, arboviruses, enteroviruses. Uh, I think also we need to rule out the opportunistic viruses. So JC virus is one, and then HIV test was it done? HSV was done. No, so HIV would need to be done as well. CMV, BV was done. Okay, good. And then the other thing, going back to the EEG, so this toxic metabolic, yeah, I'm not familiar with this CDK4 inhibitor, but CDK these medicines can have effects directly on can have neurotoxicity. I'm not sure if it has sort of has tropism for the CNS. Uh, I guess CNS areas, I guess, interfering with lowering the seizure threshold, direct pathology of the CNS structures. Aseptic meningitis, Kushal, you had mentioned that could be one condition as well. Indirectly, opportunistic infections, it lowers the immune system. So at this juncture, yeah, I'm not sure. And the MRI brain doesn't, HSV associated temporal involvement, that would be a key feature. Pattern recognition will be helpful there. But at this point, yeah, I'm wondering, number one, earlier on we entertained the hypothesis of this external medication that was taken. Number two is, does this CDK4 inhibitor directly have any bearing on the CNS structures? Number three, could there be another opportunistic infection that we have missed? So looking at JC virus and so on. Number four, looking at syndromes, or is it time to switch gears and look for any autoimmune phenomena? In this case, autoimmune encephalitis is something that we would kind of delve into if neurology comes on board and it's like nothing really has borne any results from the testing that we've done. So we need to start looking into esoteric areas. But I would at least entertain like some of those other opportunistic infections before going into sort of more rarer diagnosis. Any other thoughts, Kushal, before we send the mic back to Noor?
No, I think you covered everything, Dr. Ravi. Yes, I'm actually excited to learn from Noor now.
Okay, so you nailed it, Dr. Ravi, actually, at the end. This was kind of an esoteric diagnosis. An NS panel was sent and was positive for anti-NMDA receptor in CSF. So this was actually a case of autoimmune encephalitis. And patient was given IV steroids and plasmapheresis for like 5 days. And patient is getting that. We also did like a pelvic ultrasound to rule out teratoma, which was not present. So yeah, that was the case.
Wow. Yeah, this I was sure this was a viral encephalitis, but then this autoimmune. Though this is a great case. This is so much learning. This is what we see. 99% of the time, viral meningitis, especially up in New York. I was there during the times mosquito-borne arboviruses, and there was a rash of viral encephalitis due to West Nile virus and so on. We see that. We see that a lot. But then when your usual workup does not pay dividends, you have to then start thinking, okay, let me move to the side, to this area, which is rare, of autoimmune encephalitis. So amazing. 99 out of 100 times, this is what will play out, except for this condition. Very well presented, Noor. Excellent, excellent case. I definitely got to relearn a lot of what I hopefully had known before. Kushal, any reflections on this fabulous case?
Awesome, Ravi. Dr. Ravi, you called it out like before, and that was amazing. And yeah, I would have to read more about this. It just feels like have read it somewhere, and but it's not like I know it on top of my head as to all the all the features of the NMDA encephalitis, like autoimmune encephalitis. And I'm also concerned as to why suddenly for this patient, like just the fact that she's like immunocompromised, like I mean, they do become at risk for autoimmune diseases to come up. So if that's the only thing which is playing for this patient, of this already she already had features of something happening which was never picked up so far, or if the Chinese medications like unmask something. I apologize if you guys hear my mom at the background. I think she's getting really tense that I'm sitting and discussing a case, not packing. Yeah, so I'm going to pass my mic on to Noor.
Thank you so much. Amazing discussion. I got to learn so much from you guys. It took us like more than a week to reach this diagnosis, and you guys nailed it in 1 hour. So thank you. And it was amazing, amazing learning. I think we can go to the teaching points now, if that's okay.
Yeah, thank you so much, Nar, for presenting this case. Thank you, Kushal and Dr. Ravi, for discussing. So let's go over these teaching points from this case. We started with a 45-year-old female that presented with altered mental status for 1 day. And the first thing to consider in those patients with altered mental status is baseline. So search if this patient had a normal baseline or if this patient had a nonverbal baseline. Other than that, like considering inciting events that could be causing the altered mental status, such as medications, long flight, past medical history, such as dementia or substance use, associated symptoms, weakness, numbness, fever, or hypotension, and any previous events from before the presentation of altered mental status. And looking for the physical exam is important to identify if this patient was septic and go for stabilization. As this case was like acute course, metabolic infection usually were more chronic, so less likely in this case. And going on for the fever that this patient presented, the first thing that we should think about is infection. So because of the altered mental status, the first infection that comes to mind is encephalitis that tends to have more altered mental status and seizure compared to meningitis. So looking for the physical exam from nuchal rigidity. And another infection that could cause altered mental status are pneumonia or UTI. Important to treat these patients as soon as possible with antibiotics. Other than the fever, this patient was taking a Chinese med. This could be a noise versus a signal. If this was a signal, this Chinese med could be worsening the kidney function if this patient had a previous renal problem, or could worsen the mental status. Looking into the past medical history that this patient had, a history of cancer. So one thing to think about is breast cancer could be metastasizing to the brain and causing the altered mental status. Other than that, drug toxicity from the CDK4 inhibitor or the Chinese med could cause these neurologic problems. So at this point, we were thinking about infection versus cancer, metastasis versus a med toxicity. Um, about the capital use, this signal that this patient had a previous history of seizure, so it's important to make sure that this patient was taking the medication and if she had any aspiration precautions. So the next step at this point was to giving antibiotics, image, and steroids. Going on for the physical exam, this patient presented with a global aphasia, and it's important to know if this is a part of her normal status or this is something new. No neck stiffness on the physical exam make the diagnosis of meningitis less likely, but as Dr. Ravi mentioned, does not rule out completely the disease. And the discrepancy between the fever and the low heart rate makes us think about some cardiac history that could not lead to a tachycardia, for example. And the last thing that we had was the image. So the CT scan was important to rule out important disease such as mass. And in this case, we didn't had any mass on the CT image. The EEG, however, identify high ICP that could be occurring in some infections such as viral disease, fungal, and going to the lumbar puncture, that was the final exam that we were looking for. The CSF did not reveal a clear signs of infection. So before thinking about another cases of aseptic meningitis, for example, it's important to rule out another infections such as GC virus and HIV, but also consider neurotoxicity and autoimmune conditions that this patient ultimately have. So we finally had the diagnosis of MDA encephalitis. Thank you, everybody.
Thank you, Julie. Absolutely wonderful. You caught every major teaching point like a literal lecture on meningitis, encephalitis, and NDA encephalitis. Thank you, Kushal, for joining from India to discuss. Hopefully, you have a pleasant flight back. Thank you, Noor, for coming on and presenting such a wonderful case and masterfully presented. I must applaud you for that. And do please come back, bring some more interesting cases. Maybe a patient eating pizza having issues or something like that. So do come back, and I hope you have a great, wonderful rest of the day. Take care, everybody. See you later. Take care. Bye.